Good morning, good afternoon, good evening, everyone. We're honored to have this opportunity to co-present our leadership projects that aim to mainstream gender considerations in malaria programming. My name is Deepika Kandula, and I'm Director of Malaria Program Support at the Clinton Health Access Initiative. I provide strategic guidance and oversight of our programmatic support to governments, working with them to strengthen their national malaria responses. I'm also leading an internal initiative to identify concrete ways we can begin to address the asymmetries of power and privilege in our global health industry and what shifts we need to make in how we approach our work. And gender is one of the considerations we're looking closely at.
My name is Mary Warsh. I'm the Deputy Project Director for PMI Impact Malaria at Population Services International. Impact Malaria is the global malaria service delivery project of the US President's Malaria Initiative. My primary responsibility is overseeing the operations of Impact Malaria, but my passions lie in human-centered design, social and behavior change, and gender. Malaria is a serious disease and risk to global health. The good news is that over the past 2 decades, investments in preventing, testing, and treating malaria have led to tremendous progress in the fight against malaria. During the past 20 years, 1.5 billion cases of malaria have been averted, and 7.6 million lives have been saved around the world. So, what's the problem? Well, she knows. This is Sarah. Like the 11 million pregnant women in Africa who were infected last year, Sarah, her sisters, and her family have experienced malaria multiple times. Sarah knows that malaria still poses a significant threat to her health and the health of her children. Last year, 900,000 children were born with low birth weight, and 10,000 maternal deaths occurred due to malaria. Sarah knows that young children under the age of 5, like hers, are at the highest risk of dying from malaria. Ask Sarah to describe a day in her life, and she'll tell you that women and girls are the greatest contributors to the informal care economy. They are responsible for looking after their children and family and taking care of them when they are sick with malaria and other illnesses. But where Sarah lives, and in the countries where malaria is most prevalent, women and girls don't have the decision-making power or access to resources to protect their children or themselves from malaria or seek malaria care. Sarah knows that women carry the weight in the fight against malaria, and yet the gender dynamics that Sarah faces every day are not consistently factored into malaria programming. She knows more investments are needed to address the gender barriers women and girls face, because it doesn't matter how effective the mosquito net or the malaria drugs are if Sarah and her children can't access them.
My own grandmothers remind me so much of Sarah. Here they are at my parents' wedding in Hyderabad, India in 1965. Both of my grandmothers were married off at the age of 12. They were taken out of school, not given an opportunity to study past the 6th grade. They were relegated to the household with limited decision-making power, little agency over resources, expected to carry out the traditional duties of a wife, mother, and daughter-in-law. They were caregivers for their families. My maternal grandmother nursed my mother back to health when she almost died of typhoid at the age of 10. And like Sarah and most women and girls around the world, they are the engine of the healthcare economy, yet continue to be undervalued and under-recognized for their contributions. In fact, if we look at the formal health sector, women are also leaders in the community health workforce globally, making up 70% of this cadre. A cadre of healthcare workers that has been instrumental in driving down malaria cases and deaths in communities worldwide. Despite growing international commitment to community health workers, there has been little discussion of gender considerations for these programs. Yet every decision in designing and implementing community health worker programs has gendered implications. From deciding whose health to prioritize, to selecting who is hired for these roles and how they are compensated, to restructuring gendered norms of caregiving and decision-making in families, communities, and healthcare systems. So we can see that whether women are caregivers in the home, caregivers in the community, or caregivers in health facilities, women truly carry the burden in the fight against malaria. And yet, the fight against malaria has largely been gender blind until now. From the lack of sex disaggregated data to the one-size-fits-all approaches. While there is a growing amount of evidence on the gendered risks of malaria, there is still a big disconnect where this knowledge is not being consistently translated and factored into malaria programs in a meaningful and impactful way. My WomenLift leadership project aims to bridge this gap, starting with looking inward at our organizational malaria strategy and collaborating with stakeholders to more systematically tackle inequities that are faced by both patients and the health workforce. To inform our strategy, we're also conducting deep dive gender analyses in 3 countries, Benin, Panama, and Laos, that will give us a deeper understanding of the local gender dynamics in these countries and help us arrive at the most impactful approaches to strengthen national malaria responses. Finally, we have started exploring partnerships with local organizations to foster greater cross-sector collaboration. If we only look within the health sector, we are likely to miss critical opportunities to influence gender equality. For example, we know that if adolescent girls have access to further education, or women are given opportunities to generate income and have agency over these resources, there is a much higher likelihood of improved health in their households.
My leadership project is focused on mainstreaming gender considerations in malaria service delivery programming. Over the past year, I have been working to take gender out of the box. By that, I mean working with Impact Malaria project implementers and stakeholders to not think of gender as a standalone session in a workshop or meeting, or a separate section found in a project work plan or report, but rather to consider gender first, foremost, and throughout all our project programming. I've reframed how we talk about gender in the project, translating gender barriers as simply barriers to malaria service delivery, using language that resonates with everyone on the project, and shifting the responsibility in considering these barriers to all project staff and not just the gender experts. To support this, we've conducted gender deep dives with in-country project staff and leaders, many of whom are male and may unknowingly be gender blind themselves. It takes work and change can be slow, but we are making progress. Achievements this past year include successfully advocating in one country to interview community health workers about the gender barriers that affect their work, and to include modules on gender and malaria in national health worker training curricula. Another achievement was conducting qualitative gender assessments in 2 project countries, Cameroon and Kenya. As Deepika mentioned, there is often a big disconnect on how existing evidence around gender is systematically and consistently factored into malaria programming. I am a firm believer that knowing how gender affects malaria service delivery in your own local context can serve as a powerful impetus to take action. And that's where the next steps come in disseminating the assessment results and adapting approaches to malaria programming in the assessment countries, and then disseminating the results more broadly. Which brings us to the future and life beyond the WomenLift health journey. WomenLift Health has given us a valuable platform to expand our network and connect with others doing similar work in mainstreaming gender in malaria programming. It's given Deepika and myself an opportunity to share common challenges, identify synergies, and explore opportunities to amplify our collective voice. Last week, Roll Back Malaria and Malaria No More launched a report on the case for investing in a gendered approach to the fight against malaria. We and our respective organizations had the opportunity to contribute to this important advocacy piece, and we hope to continue fostering collaborations like this one. We also plan to jointly hold an external webinar, highlighting and sharing with the wider malaria community the learnings from our project's gender deep dives and assessments. We want to continue using our collective voice to increase accountability, create linkages across sectors, and champion a more proactive approach to gender and malaria globally. We would like to thank WomenLift Health and our supervisors for supporting us on this amazing journey. Thank you.
Thank you.